Absolutely not. Absolutely not. It's sort of it's a consent, if you will.
Correct. And then just so you know, in the recording, I'm Joyce Cockle-Reese, and I'm the COO of LifeSpan, and I met Lindsay at the ASA conference last March now. It's been a while. And Lindsay is the Executive Director of the Consortium for Older Adult Wellness, is doing this great program that I thought would kind of be interesting for us to look into also. So, Lindsay McIntosh, I'm going to let you talk a little bit more about you because that's what I know about you.
I'm doing some consulting, and I trained to be a leader of the Chronic Disease Self-Management Program in 2008 and joined staff later that year and was a coordinator and then was a manager and then was a vice president, and now I'm executive director. And what is really lovely about that journey is that our executive director is now in the role of founder and our dean of our academy. So we still have a lot of the same folks on staff that we've had around since the beginning. And so we've been doing this work a while. And so I'm happy to share what we have learned. Part of what we have learned, as I've shared with Joyce, we've done by hitting our head against the wall repeatedly. So if we can save you some of that, we are happy to do it. So with me also is Joni Saunders, and you may hear her in the background. She is one of our program coordinators. She's working with some of our small pilot projects we're doing with WellPoint Anthem, and she's also going to be working with the rollout of our diabetes prevention program. So please let me know if the volume needs to be up or down, or if it sounds like I'm screaming at you, because I get passionate, but I don't want to scream at you.
So we like passionate.
So what I would love to do is just kind of get an idea why we are all here. I know what I'm here for, which is this is the learning objectives that Joyce and I had worked on, and I will not make you recite these, but we want to just go through what's happening nationally and get just a little bit of a feel for that, and then talk about what's happening with the connection between practices and health systems and community-based organizations, and how that bridging is happening. And we want to do that by talking about the National Committee for Quality Assurance Standards as a way to make the connections, explain the connections, reinforce the connections. And then the real goal for the 3 webinar series is for us to be able to give you all options and details and have a discussion around establishing a referral system that will really strengthen that connection. So the background pieces that we're talking about today, we're going to be referencing over the next 2 webinars as well. And what will happen in the next 2 webinars is we will really dig into the work of establishing a referral system, making the connections, reinforcing the connections, messaging, et cetera, et cetera. But we're going to start with a little bit of the background. And the big overriding goal is this last one, which is the objective is to really acknowledge the vision you all have and help you create what you want to do. And so that is our overriding goal. And I'm hoping while we are at this point, you all could share with me
what I'm looking to get out of today is just anything that we can use with our clients to help serve them better.
Okay.
You're next.
I'm Lisa Fry, and I'm the guardianship manager. We are have a team that are legal guardians for anyone 18 and over. So we work with physicians out in the field, help make medical decisions for the client, along with them, work with various agencies, making sure they're living in a healthy, safe environment. So any...
Great.
Hi, I'm Tika Reinhold. My title here is Volunteer Coordinator. I pretty much do anything and everything that I can do for the agency that will help our staff. Additionally, I'm a health education and promotion master's student, and I'm a thesis away from that degree, and I'm certified. I'm a certified health education specialist.
Great. So you have a full plate.
Yeah. Hi, I'm Bill Saylor. I'm the CEO of LifeSpan, and Joyce and I have been talking about this for quite some time. Not only how it relates to our existing programs and services and how we do those, but seeing things out in Colorado, and I must admit to being a little fuzzy to what the process and the implementation looks like. So I'm very interested to hear more about that.
Great. Nice to hear your voice. Thank you for making this happen for all of us.
I'm Dan Barron. I'm also a supervisor for the Elderly Services Program. And like Lori, we're just looking for better ways to provide the best amount of services possible to them.
I'm Paula Jones. I'm the manager of Family Connections here at LifeSpan. It's kind of a small portion, small little corner of LifeSpan that we're trying to grow into a bigger area. Helping seniors navigate out in the community to connect them with additional services and things to keep them in their homes as long as possible.
Wonderful.
Hi, I'm Catherine Biddleman. I'm the finance director at LifeSpan and team services for the agency. I get to find out how we're going to pay for it or make money from it.
Hey, okay, great.
And I am Emily Doherty. I'm the Human Resource Director here at LifeSpan, and also part of the management team. And again, I'll be involved in any implementation needs, staffing needs that might be associated with adding new programs or new elements.
Wonderful.
Hi, Lindsay. I'm David Mancuso. I'm the last one. I am, and just wanting to help position us going forward. So.
Wonderful.
And then we have Katie on the other line somewhere.
Yep, I'm Katie Furnace. I'm the program manager for Elderly Services, and I'm kind of interested in just how to connect with physicians' offices out in our community. That's kind of a link to our program that we don't have a strong connection with, so I would be interested in how this could help with that.
Perfect. Great.
I think that's everybody.
Well, wonderful. That is really helpful. Thank you all. And what I'm going to try and do as we go through this is relate it back as much as I can to what information you've given me, knowing that when you're really going to see the connection is next webinar. So I'm hoping that what we go through today will be a review for some of you and new stuff for others. And to borrow what Bill said, we'll try and defuzzy as much of things as we can moving through. So thank you very much for that. So first thing is we want to make sense of healthcare, which if we can pull that off in one webinar over an hour and a half, we will be doing great because it's all a little confusing. But what we want to do is look at this from the point of view of what you all are trying to do. So we want to look for opportunities for scaling, sustaining, and what your role is within this. We're going to talk about some successful models and implementations, and then we're going to talk about the NCQA standards and elements that are how we have found a way to get in and talk with practices and talk with care transition folks on and the services that are available. So that is our entry into the door. So that's what, so statistics, these are from the CD. This is probably every time I look, chronic diseases. 1 out of 2 adults has a chronic disease in 25. And probably that is high. 1 of 3 of us is obese. Those with arthritis tend to be the ones that are also overweight or obese. Again, mostly, so that's 9% of all adults. And this one gets to me every time, that diabetes is the leading cause of kidney failure, non-traumatic amputations, blindness for ages 20 to 74. Now, I would have thought 60 to 74, but 20 to 74. And 67 million adults will have doctor-diagnosed arthritis by the year 2030. So there's just a little reality check of where we are as a nation in terms of health. Another point, and especially those of you who are working in elder services already know this, which is we as a nation are aging, and we know that 10,000 new people, new retirees, are being added to the Social Security rolls each day. That's amazing. So we know that we are getting older, and we know that as we age, we are seeing more and more arthritis, chronic conditions, et cetera, et cetera. So the trend is that we are seeing a greater percentage of people who have more than one chronic condition, as if one was not enough. So we tend to be overachievers. So 90.7% of us over 65 have one chronic condition. 73% of us have 2 or more chronic conditions. And here at COA, we've been doing these classes, these evidence-based programs, some of them starting as early as 2001, some of them starting in 2007. And so we have a fairly good feel on data for the chronic disease program. And we have now about 14% of the people who've gone through our chronic disease program tell us they have 4 or more chronic conditions. Now, these are the folks that are still well enough to get to classes, and they are walking around with 4 or more chronic conditions. So another thing that probably won't be a big surprise, but it's always rather staggering to take a look at this graph, which is 30% of what's happening with chronic conditions is related to genetics, is related to our access to health care, those kind of things. 70% of what happens with chronic conditions is really within our own behavioral activities, our environment, what we do, what we don't do, smoking, poor diet, inactivity, falls, alcohol and substance abuse, stress, social isolation. That accounts for 70% of the risk factors for chronic conditions. We know that 75 cents of every healthcare dollar is spent on what is largely preventable, highly manageable chronic conditions and diseases. So that's 75 cents out of every dollar in healthcare goes to those things. So we also know, thanks to the Centers for Disease Control, that 80% of heart disease and type 2 diabetes, 40% of cancers could be prevented by doing 3 things differently: exercising more, eating better, and avoiding tobacco. So we know that. We all know that. The trick is getting us to do that. And so we also know at that same time that we are spending less time with our healthcare providers. So the Centers for Disease Control put together their 4 domains. And these are their 4 categories that they are really working on. The first one is epidemiology and surveillance, environmental approaches to health. This third one, domain 3, is health system intervention. And this relates to improving delivery of health care, being able to increase preventative services, diagnose diseases earlier, eliminate risk factors, and mitigate complications. This is probably the one that relates most directly to what we're talking about, which is strategies to improve community clinical connections. So what that relates to is how do we connect a patient with what's happening in their community to reinforce better health. That includes, according to the CDC, activities that are available to folks with arthritis, diabetes, chronic disease self-management programs, physical activities in the community, in the work site, rec centers, YMCA programs, other local organizations. It also, within the domains, refers to the increase in Centers for Disease Control's evidence-based lifestyle programs. Now that includes those that we're going to be talking about and that you are looking at setting up referral systems to. So that refers to the Chronic Disease Self-Management Program Series out of Stanford, as well as the Diabetes Prevention Program Series out of the CDC. The CDC also talks about implementing systems to increase provider referrals, which is what this is all about, so that people with pre-diabetes or multiple diabetes risk factors have a way to get into programs and to use allied health professionals to enhance management of conditions like high blood pressure, and to use allied health professionals and providers such as nurses and dentists, community health workers, patient navigators to really support these activities and this connection piece. And then they're also urging that a practice really look at the systems they have in place and help make that connection possible for patients. So one of the things that is happening with the 5th area, whoops, let me see if I can go back one. Domain number 4 also refers to really ensuring follow-up care and ensuring and being able to show that connections to community-based organizations are appropriate and successful. Now, they don't have how they're going to measure that, but they do want it to be an effective connection rather than just a connection. So far so good? That's a little daunting. So this is perhaps this is how we fix it all. This is the Centers for Medicaid and Medicare Services triple goal, which is better care, better health, lower costs. So if we get that done right away, we still have lots of time to talk after the webinar. But that's a lot to accomplish. So we have the CDC 4 domains. We have the CMS triple goals. And now we want to talk about how we're going to connect all of those pieces and moving parts to actually making changes for people in their own health. So this is the Institute of Medicine's definition. We're going to do a little less fuzzy. Hope what I do or what I don't do when I'm not with my healthcare provider. So I can positively self-manage. I can pretend I'm not self-managing and avoid the whole topic, but that is making choices and self-managing. It's just not doing a great job of it. But we're going to define this as self-management is what I do, what I don't do when I'm not in the clinic. So that includes what I eat, what I don't eat, what I drink, how much I move, how I think about what's going on in my life, how I address the barriers in my life, any socioeconomic situations, how I think about those, whether I medicate, whether I smoke, how much sleep I get, etc., etc. And the successes of the CDC 4 domains, successes of the CMS triple goals, the success of healthcare transformation and cost savings that are discussed within the Affordable Care Act, all of that depends on me, the patient, the individual, doing things differently. That's it. That's what it comes down to. Here's the program. So Joyce has seen this slide before. Do something additionally needs to make a change in order for things to get better. Engaging the person is the only way to do that. Within a lot of the work, whether it's the CDC, whether it's CMS, whether it's the patient-centered medical home work that we're going to be talking about, there are a lot of process measures. They are looking at foot checks, A1C levels. The dashboards are too numerous to go into. But you can measure all those things all day, every day. For example, let's say I have diabetes and you want me to track my A1C. And as a practice, you are tracking my A1C. And as an insurance company, you are tracking my A1C. You can track that all you want. But if I don't change how I'm eating, how I'm exercising, whether I'm compliant, screen to change. There we go. Okay. A moment of panic there. Self-management support. So self-management support is the systematic provision of education and supportive intervention. Great. We're going to do a little bit less highbrow version of that, and we're going to say for our purposes today, self-management support is how LifeSpan, how a medical practice, how the health systems, how all of these different things that you are involved with, whether it's guardianship activities, whether it's home health, whether it's elder care, whether it is helping people connect to resources in the community, how does all of that support me as an individual and me as a patient in making better choices? So self-management is what I do. Self-management support is what the systems, what you all do to support me. Does that make sense so far?
Yes.
Okay. So self-management education is going to include all of these different pieces. So that refers to enhancing patient self-management. Now you will notice that this description, which comes from the CDC, is not referring to any particular program. They're referring to education that's on skills such as setting, better choices, problem solving, self-monitoring, but all of them are about how do we teach me to make a little bit better choices. So evidence-based approach is very that we're trying to talk about when we talk about self-management education. It's a skill set around managing what's going on in my life and making choices. And again, choice is a big word in this, and we'll be talk about how the practice, how LifeSpan, how health systems and insurers can support me, what self-falls into a whole slew of categories. It can be how a practice handles treatment goals. Are they including my own personal goals, my self-management goals within the treatment goal? And help in assessing barriers to health. Are we talking about my willingness to change? Are we looking at education resources? Are there self-management tools available for me? Things like food plans, blood pressure logs. Management education piece comes into this. So if you just hand me a piece of paper and say, here's your new food plan, but we don't spend any time talking about why I need that, why it's important, what to do with it, what I'll learn from it. Tracking those referrals, providing education resources, all of that comes back to self-management support, and then they want to do, and how through education, through connection to community resources, through reinforcing things through self-management support, how do you help me get there? So we talk a lot about the importance of evidence-based programs, and evidence-based programs can fall into a number of different categories. They can be the chronic disease suite out of Stanford. They can be diabetes prevention. They can be falls intervention programs like Matter of Balance, Stepping On, In Balance, Tai Chi programs, exercise programs, wellness programs. But evidence-based is really the key. If you are looking at something that is evidence-based, you are looking at something that is been shown and approved and given the blessing of the Centers for Disease Control and or the National Council on Aging. Both of them have programs that they feel meet the criteria to be considered evidence-based. So when through statistical evaluation has been shown to be effective time after time after time, has research behind it, has a fidelity component. And that fidelity component is important because what it means is that if we're delivering a program in Colorado and you're delivering a program in Ohio, we can expect that our participants will have very similar outcomes to the intervention. And so it's the evidence-based programs that are being looked at as what will be reimbursable, not only from private payers, like insurance companies, but public payers like CMS. So evidence-based is really key to what we're talking about, and we'll come back to what that difference is when we move along. Another thing we want to take just a little bit of look at is whether we want to look at embedded programs, community-based programs, what the difference is and why we would want to do this. So in clinical practice, why would you want to work with community-based organizations on evidence-based programs? And if you're a community-based program, why would you want to work with a practice? And if you're LifeSpan, why are you interested in this connection of the clinical piece to the community? Why do you want that to happen? Anybody want to chime in on that?
Well, I think you have to look at like the whole person, and if you're only dealing with one piece and somebody else is dealing with this other piece, there's a lot that gets missed. So I feel like to do wellness, you kind of have to have that overreaching, that you're kind of that extended arms. I don't know if I'm saying it well, but
I think you're saying it very well. Thank you. Anyone else? An individual, what better than to help them from all different fronts at once. To support me through LifeSpan activities, to support me through my medical practice, to support me in community-based activities. What better way to show that I am important and to reinforce the positive changes that you want to see happen for all of us by involving yourself in self-management support. When we work with clinics and health systems, one of the questions we have like a whole practice meeting is we'll say, whose job is it to kind of looks at everybody else in the room and points, because no one's really sure whose job that is. You can track whose job it is to check in a patient, whose job it is to fax a referral, whose job it is to give a shot. But whose job is it to spend a lot of time responsibility to what we want to do is help kind of change the paradigm a little bit so that that connection piece that you can help make possible is something that supports not only the practice and not only the community-based organizations, but also really supports the patient. And why they would want to talk with you about what you're talking about bringing to them is that what you are talking about bringing to them is something that keeps them from having to reinvent the wheel. We're going to move into how the MCQA figures into all of this, but it's important to note that the programs that we're talking about, these evidence-based programs, to accomplish what the health systems want to accomplish, what want to accomplish, a loop where we can all be moving, shift in patient interaction. And we'll talk a little bit more about that. But one of the things that we just had said earlier is that it's really hard when you realize that the changes have to occur on an individual basis. And how do you document that shift? How do you changes, and I'm working on changes. Now you may be able to show it down the road when my A1C goes down, or some other thing that would have happened had I not made changes. But in the initial stages of someone making changes and making different choices, to be able to document it in terms of patient interaction and patient involvement is very definitely data, real increase in patient activation, patient engagement, both in terms of the research numbers and anecdotally. And there's also a real increase in terms of patient confidence levels. The feeling that their practice is behind them and that they are not in this alone helps them to make conversations and decisions and choices easier for the patient. Anything else you all want to say about that piece? Okay. So, the Affordable Care Act. So for our purposes today, we want to talk about what the Affordable Care Act says as a way to increase access to health care. And to expand prevention and wellness. But because we want to be able to relate it again to self-management support you all can provide, referrals, which is our goal, and there are ways to get to this. Some of them you have already experienced just by the function of the jobs that you have within LifeSpan. So things like care coordination, lower hospital readmission, preventative services, greater access to health care, lower emergency room usage, medication management. All of these pieces are referenced within the Affordable Care Act. All of them create opportunities for making connections and helping connect, again, the clinical to the community-based classes. So that's the part we're going to refer to within the Affordable Care Act, because there are some pieces that are referenced and some that are not. So we're going to talk a little bit about what is a patient-centric medical home. So I would have you all raise your hands if you were here at home and the National Committee for Quality Assurance. Are you experts?
I think very little.
Okay, that's
It's
good.
a consensus.
I have a whole bunch of slides for you, so we want to make sure we're not boring you, though. Okay, so we'll just go through this. If I'm telling you stuff you already know, please say something, okay? So a patient-centered practice, a patient-centered medical home is a real shift in how business is being done. The goal is for a practice to really, as it being a physician or the practice being a gatekeeper to services. This is very different, and it's based initially on primary care. Patient-centered medical homes came out of pediatrics. They now are primarily primary care, but they have now expanded it, and there is now specialty, patient-centered specialty homes. There is a movement to include not only medical homes, but medical neighborhoods, which is basically what an accountable care organization becomes, is a patient-centered medical neighborhood, meaning not just what happens within the clinic, but what happens in my greater world. So a primary care team is at the heart of a patient-centered medical home. So I'm right in the center as a patient. Around me is a team approach, and that could include my doctor, or it could include the nurses, the clinic support staff, pharmacists, outside specialists, home health aides, the people that help me connect to the services. It could be my guardian, who not only has my best interest at heart in terms of finances, but in helping me understand how to make healthcare decisions. It can be patient representatives, but the patient remains at the center of it, and the team shifts based on what the person needs. So it may be that there is a surgeon on my team for a while. It may be there's a physical therapist. It may be that there are classes that are a part of my team. But it's going to move around a lot, and the team will be different for every person. Now, there will be some things that are similar, and that's part of where the legislation comes in, because if I have a patient panel, if I'm a physician, and I have a whole group of patients that have a chronic condition like arthritis, then I'm going to have those same services available. Those same parts of the team will be available no matter what the patient's name is. They will all have access to those same things, but they may have other people on their team as well. They may have family members or they may not. They may have services that provide transportation, or they may not need that. They may have a grandson that always goes to appointments with them, or they may not. So the team is going to shift, but some pieces will be consistent. So again, it's systemization across sites, some standardized resources, standardized practices, standardized training, standardized access, and a lot of knowledge and support of what a patient needs. So support, standardization. That's really hard to say quickly 3 times. Let me just say that right there. But standardization and support of the patient are key. So patient-centered medical home, as I mentioned, the patient. It's all about their personal physician, and that's for not only chronic care, but for acute care or continuous care. Moves from one situation to another, the whole team is involved. So I just said the team changes a little bit. So let's say I am a patient and I go from being seen in a doctor's office to being an inpatient in the hospital, and then I go in, and then I'm going to need to get some physical therapy, and then I may be ready to do some additional physical therapy that are a part of that team approach. Okay? So you got the patient, you have the physician at the center, you have the team, and then this is the biggie, the care coordination piece. And I'm really excited to hear what you all are doing with LifeSpan, because this is so key, not only to working out how to make the referrals work, but there are so many places where what we're talking about doing with evidence-based programs and referrals fit into what you're doing with coordinated care. So a large part of patient-centered care is to make sure that the tools the patient needs, they have. The education to use those tools, they have. Again, if you give someone a blood pressure journal so you can watch what they're doing with hypertension, but you don't talk to them about why or how important it is, or if worst thing, they come back with a log complete and nobody takes a look at it, then you got some problems. So there's also, the goal is to ensure that patients have the capacity and the knowledge to make the most of these efforts, and to really work to develop a collaborative approach to the treatment, and a collaborative approach to setting goals, and a collaborative approach to reaching health outcomes, so that things are not done to me, but for me, with me. Most important, with me at the center. So there is evidence that a patient-centered medical home works. Continuity is associated with reductions in mortality, reductions in A1C, and then we've also seen I'm on a committee with the Patient-Centered Primary Care Collaborative, and they did a 2013-2014 review and found that within a study of major university studies, 6 out of 10 studies showed cost reductions associated with becoming a patient-centered medical home, and 12 out of 13 of the studies reported increased cost savings in utilization were reduced up to 92%. So there is evidence that going through this patient-centered medical home process works. I would say that there is also times when it is best to intersect with a practice going through transformation. Then there are times when it's best to not add to what they're going through. I think that when they look at cost savings, one of the things that is a variable is where they are in their conversions to electronic medical record systems. So if you're talking with a practice who's just getting started in EMR, they will not see a cost savings, and they will not necessarily see it as a positive thing. However, if you talk with them a year later, then they're going to be seeing the savings, and they will be seeing happier, healthier patients. So just by the fact that they're looking at the data differently, and they're looking at the patient differently. So there are a number of different ways that you can look at what is a patient-centered medical home and how do you become one, how do you call yourself one. The National Committee for Quality Assurance is a nonprofit organization that is really designed with a vision to transform healthcare. So they are looking at what is important to measure, and then measuring it, and then promoting improvement. And the NCQA is considered sort of the big dog in this, but there are a number of other organizations that also do the equivalent of NCQA recognition. Joint Commissions does that for hospitals. There are some organizations that also work through state-run or state-specific private insurance payers. So they will have a set of recommendations that are very similar to what we're going to talk about for NCQA, and that's how people within certain health systems within certain states, and I'm thinking of Michigan specifically, can say, okay, we are a patient-centered medical home because of our agreements with this company, we know we are meeting these benchmarks. So I'm going to talk about the NCQA because it is sort of considered the gold standard at this point, but know that there are others out there, and know that you can become a patient-centered medical home in terms of the work, the transformation work, changing how you do business without ever going for recognition through the NCQA. But the NCQA is still considered the one most people go for. So what we started doing was working with practices and health systems that were interested in healthcare transformation and were in the process of applying for NCQA recognition. We started that work back in 2009. And since then, we've gone through the 2008 regulations and the 2011, and now we're on 2014. So I'm going to reference the 2014 and tell you that one of the new things is a real true integration of behavioral health, a recognition finally that behavioral health is so important not only for physical health but for self-management and for just being able to access services and being able to really self-manage what's going on. So it's very much written into the new guidelines, as is care management. And the care management is focused on high-need, high-risk populations. They're really gearing toward what are the socioeconomic factors that have an impact on whether a person is able to make changes, get access to care, has the ability to self-manage, needs support, and if so, where, needs services brought closer to their community, et cetera, et cetera. We've already talked about there's a real emphasis on the team-based care. It's in alignment with the AAA. And another big piece of this is the idea of sustained transformation. I would say back when we started working with practices in 2008, 2009, sometimes it was kind of frustrating because we worked with the practice and they would say things like, what's the quickest way to get this done? What's the easiest way to talk to our patients about making changes? Because we want it fast and it doesn't necessarily have to stick. We just want to make sure we can say that we did it and check the box. Well, NCQA has changed how they're doing business, and they've changed how the process works. So it's no longer, there isn't a way anymore for a practice to check the boxes. It's about not only being certified once, but sustaining that transformation. And what most practices and health systems will tell you now is that becoming a patient-centered medical home is the beginning of the process. It's not the end of the transformation. It's a marker that shows you have achieved certain benchmarks within transformation, but it's just the beginning. So these are the 2014 standards. You guys doing okay?
Yep. Sure.
Okay, no news is good news. You're going to stop me if you have questions, correct?
Yep.
Okay. All right. So 2014, these are the must-pass items. Now, there is a lot of work that goes on for a practice or a health system to become, to complete the application process to be recognized as a patient-centered medical home, either level 1, level 2, or level 3. And I'm not going to pretend to go into all of those details. What I wanted to show you was how self-management support, care management, all of those integrated things that we've been talking about weave through each of these 6 standards within patient-centered medical home transformation. And all of these places are places where within the work that you are doing in your current job descriptions are places where you can intersect with this work. So the first one is patient-centered appointment access. And I have to tell you a story. So we worked with the Colorado Community Health Network, and that is a membership organization for federally qualified health centers. And back, well, we're going on 5 years ago now, we started working with them in a project that was funded through Kaiser Permanente Community Benefit Program. And the idea was that Colorado Community Health Network wanted all of the community health centers, the federally qualified health centers in Colorado, to become patient-centered medical homes. That was the goal. And what our premise was in working together on this project was that it was pivotal for a community health center and their staff to really understand the importance of self-management and self-management support and patient engagement in order to make that transformation not only work for the practice and work for the patient, but work for the staff. So when you talk about something like patient-centered appointment access, a staff may tend to say, why do I care? It just makes my life more difficult. And why do we need to have appointments after hours? And why do we need to have appointments available same day? It's much easier if we have it all set for months in advance. Well, when you can work with a staff and you can work with a whole practice around, if you think about it from the patient's point of view, if you think about it from what can you do to support a single patient who has a healthcare issue and needs to see somebody, then suddenly all the things that are being asked of the staff, whether they're front office, back office, medical assistant, all makes a little bit more sense. And so we started approaching it from that point of view and from conversation around whose job is it to support the patient. It's everybody's job, from the person who's checking people in to the person who's setting appointments to the person who's handling the billing, much less all of the healthcare team. So we found that through working and viewing self-management support as really pivotal skills with the community health centers, the feedback we got was that the team was happier. The team was more involved and saw the reason for all the additional work. And the patient and the staff measurements on how satisfied they were with the process went up, in part because they felt supported. Now, did that mean everything was perfect? No, but it meant they felt like there was a way to talk to people if need be. So when I say something like even this first one on patient-centered appointment access, there are ways to intersect with that in terms of referrals, in terms of the importance of self-management support. Obviously, the second one here is just the practice team. And this first one we just talked about. Okay, second one here. This is the team-based care one. And you'll see that there are 2 things in here that I think are really important. One of the handouts you're going to get is a little grid version of this. It's kind of hard to read, so I thought I would just kind of spend a little time on this one. What we want folks to see is that patient and family education and self-management support is something that is a requirement now in the standards. And being able to document that members of the team are assigned to support patients' families in self-management and self-efficacy and behavior change. So that means someone on staff has to know how to do this work. And that is a huge place, a huge window, if you will, of opportunity. So if you're working with a practice, who is it that is working, who is it that has that task? Now, sometimes the people that are tasked with this have a lot of experience and know exactly what they're doing and what they want to do, in which case they are overwhelmed and would love your help. Sometimes they do not have the training and are not sure what this means, and then it will be greatly helpful to them that you have some answers on what is possible, what connections are out there, what training is available, et cetera, et cetera. So population health management refers to not only the system that says this is what we do for everyone with this diagnosis versus this is what we do with everyone with another diagnosis, but how they are viewing behaviors, depression screening, health literacy. This is my favorite one. That's why it has the star. Actually, I have two favorites now in the 2014s, but this one is important because this is where the care planning self-care support. What is the patient's preferences? What are the treatment goals? What's the self-management goal that fits within the treatment goal? Medication management, self-support care, self-management tools, and self-management tools can be those things that we talked about, which would be a blood pressure log, a food journal. Could also be the strips to test your blood. It can be a booklet on exercise techniques. It can be brochures. It can be all sorts of things. But it isn't just about the tool. It's about the structured health education, the classes, the peer support, and how to use those tools effectively. And then there is a piece there, number 6, is a list of community service areas of import. So if you are a practice that is seeing middle-aged and older adults, you want to have 5 community service areas that fit with the patient panel that you are seeing. So if you are not seeing children, but all of your 5 things revolve around pediatric care, well child visits, and daycare, that is not appropriate. If you're a pediatric practice, it's very appropriate. So when we work with practices on this list of community services, we will give information like rec centers that are close by that have programs available for people who are new to rec centers. We will have things like the quit lines or the smoking cessation program. We will have information on how to access community resources like the Chronic Disease Self-Management Program or Tai Chi classes. And so it's about what is specific to that community close by. And the reason they went with this list of 5 is that what used to happen with practices is there would be one person who had a big book that had every resource imaginable within a community. And we used to laugh. We'd go into community health centers and they would say, well, I have a patient who has the book. So that somebody would be in with a patient and they were looking for how can we help them connect to help in paying their utility bill. But unless you have that information in front of you, nobody knew where it was. So you'd have to hunt down who it was that had the book the last time. And rather than having that kind of a system, there's a real push to have an ability to access those resources and to have a list of the frequently requested things available for every patient. So that's where that list came from. And the other piece that I think is new and is wonderful is this number 7, which is what is the usefulness of the community resources? It isn't just about referring people to programs, but do people go to the program? Did they make changes because of the program? Did the program call them back? Those are all very important things. And did it translate into something the practice needs? So number 5 also gets a star. This is the referral tracking and the follow-up and to coordinate care transitions. Now, I don't know how much work you all are doing with care transitions work. The care transition piece is if I go from not being in a hospital to being in a hospital, that's a transition. If I go from being in a hospital to being in rehab, that's a transition. If I go from rehab to skilled nursing, that's a transition. If I go from skilled nursing back to the hospital, that's a transition. And how is all of that handled? how are services handled? Is all that information going back to the primary care team within the patient-centered medical home? And what are the opportunities to connect and to coordinate with those care transitions? Now, obviously, if you're wanting somebody to take a falls prevention class and they just fractured a hip because they took a bad fall, you want to wait till they are able to ambulate again. Talking to them about, we want you to go into this class and we're going to refer you into this class, when they are a few days out of surgery, it's not a good time. Perhaps it's a good time to plant the seed, but it may be 4 to 6 weeks later when it's really time to make a referral. So how do you set up that kind of a workflow so that you know when it is appropriate and when it's not appropriate? So I'll give you an example. One of our partners recently did a brochure, and they sent the brochure out on the meal trays for Meals on Wheels. But the meals within this area where they sent those brochures out were people that were homebound. And so they wondered why no one had responded. And it was because they had sent brochures asking people to come out to a community-based class, self-managed, to people who were no longer able to leave their home. And so they didn't get a lot of response. Now, perhaps there was a way to do that, and perhaps that was an appropriate thing to do to reinforce other programs or to introduce programs that would come into the home, or to introduce the idea of, we will come pick you up and take you to this program. But you have to kind of think through the workflow and when is the time to really intersect with that transition. The referral tracking piece is what we're going to be talking about next webinar. The referral tracking, when we talk with community health centers and practices, what we say is that we want them to refer to us and treat us as if we were a specialist. So we are a specialist in community resources. We are a specialist in chronic disease self-management programs. We are the specialist working with the patient on connecting them to a diabetes prevention program. And so we handle those referrals in the same way, and we provide feedback to the practice in the same way in their language. We have made the offer several times to people who are going through the transition. Referral tracking is such a hot button for practices, especially in the beginning of transformation work, because they feel like they're sending missives out into the fog and they're never sure what happened. So we say, well, practice with us. Send referrals to us. We'll follow up right away, and you can start getting your systems and your workflow working with just a small little community-based organization. Then you can take lessons learned and apply them, if you want to bigger fish, like a hospital or a specialist. And number 6 is performance measurement, quality improvement. And again, this evaluates not only access and communication, but that whole person care and self-management support. I know we have folks from the finance world on the phone with us, and so one of the things that we heard back from a billing department at a practice was, if a person is engaged and feels like the practice is really on their side and supporting them, when there is a problem with billing, when there is a problem with insurance, when there is a problem with co-pays, it's much easier to talk to a person who feels like the practice is on their side, rather than talking with a patient who feels like the practice is against them. So even self-management support can be very helpful to the folks in the back office as well as the medical folks. So, self-management support. This is what all this means, how all this comes together. When you look at the NCQA, when we look at all of these different pieces together, what it means is that educational resources are important. Using the electronic medical records to identify specific educational materials. So, for example, a patient panel, a group of patients that all have a diagnosis of arthritis will all get this information. And it may be things like managing diet, it may be things like managing activity levels, but whatever that is identified and it is in the EMR, to use the EMR to identify those patients and provide specific educational materials. So if I don't have high blood pressure, I don't need a blood pressure log. To develop and document self-management plans and self-management goals. And to talk about and assess the ability and the willingness to change. This is something that we do a lot of work with the team on, around what is the, if everyone is going to be talking to me as a patient, what are you all going to say? And where this comes into play is everyone working at the height of their licensure, so that I may be talking to the person at the front office, and they may be checking me in. But if they take the time to smile and to say, it's nice to see you again, welcome back. And while you're here, they're going to be talking to you about what happened with the goal you set last time. That is a way to support me that does not require medical school, doesn't require a lot of training. But it's also about using the medical assistant who's going to be walking me back to the patient room, the exam room, and so that that medical assistant knows that it's appropriate to ask me how I'm doing with walking 3 times a week, or how I'm feeling genuinely asking and making eye contact, as opposed to the usual thing that happens in those short exchanges, which is, how are you today? I'm fine. How are you? Well, my kids are home from school. Oh, well, my kids are home too. Okay, well, the doctor will be in a minute. So for that same amount of time, you can have a positive interaction. That is part of what your provider is going to do while you're here, is talk with you about some new programs we have that could really help you feel better. So I'm, with your permission, going to let them know that you might be interested in some of this information. So that's the same amount of time, but it's a very different message, and it helps set up a willingness to change. And those are all motivational interviewing techniques, and they are fairly simple for a practice to start putting into their workflow. So we do some work around that. And then again, there's things like provide self-management tools and counsel patients to adopt healthy behaviors. Now, that sometimes is a referral. I'm going to refer you to this program. It's going to help you feel better. And we've talked about how we're going to help you manage your diabetes, arthritis, COPD, whatever. And so we're working at it from the medication side. I want to give you some additional help to help you really adopt some new, healthier choices. So we're going to make that referral today. That comes to the crux of the matter, which is what does all of this mean when you put this together? So we know from the information from community health centers and the National Association of Community Health Centers that the care management and support pieces, that standard 4, that those are the most difficult for community health centers to meet. And why? The question is why? Because you would think talking to a patient, supporting a patient would be the reason people got into this field. But it's such a different way of viewing the importance of a patient, and it's such a different way of viewing the process that standard 4, that care management and support, self-management and self-management support, all of those pieces tend to get pushed to the very end. And then what happens is the practice tries to go back and insert the patient in a few of the things that they're already doing, which is much tougher. To actually do care management and support requires care teams, and it requires them to be working effectively. And so that takes practice and that takes time. There are also workflow adjustments that have to happen. I remember a provider saying to me once, "You ask a lot of questions, you're one of those, aren't you?" And I said, "Yeah, I am one of those." And he said, "Well, then we're going to have to make sure that we schedule you at the end of the day, because if I have to answer questions, I don't know." Well, so I changed doctors as the upshoot of that. But to have the time to do that is important. And then the documentation piece. How do you document self-management support? And communicating with patients is not a skill set that comes in medical school. This is something we have heard again and again and again from providers. We've had providers say things like, our nurses are much better at this than we are because they are more people-oriented than I am. And I think that's really very true. So what does this all mean? What this all means is that you have opportunities, and why these standards are important is that this is really about making connections. It's really about standardization and creating openings, and it's really about sustaining the work that you want to do. And leaning on these standards that the practice is doing their best to try and meet creates an opening and conversation points for you. So, LifeSpan will have the answers. The question is, how do you pull this all together and why does it matter? And the answer is time and money. When we talk with practices a lot and we do this brainstorming about what is it you would like to do, what keeps you from doing that, and to a practice it comes down to, well, we don't have the time for it, we don't have the money for it. And the practice managers, the finance folks will say, well, the time is the money, and the money is the time, and we don't have either. So all of the things that we're talking about take time, take training, take follow-up. What we're suggesting is that what you have as a skill set can help the practices, can help the community-based organizations make those connections. You will be able to go in and save them time and money and help them better do what they want to do. And in the meantime, you are helping them to do what you want to do as well, which is support patients in better health. So what we're saying is these guidelines really stress connection with community-based opportunities, with healthcare, with medical neighborhoods, with the kind of services that you are bringing to the community and to the patients. So you're in the driver's seat on this one. You can save time, you can save money. So I want to real quickly just go through a couple of pieces and parts that we will reference again moving forward. And I'm still counting on you guys to holler at me if you have questions. We'll leave some time at the end too. But just a couple of things, a couple of words about what the clinic and the medical world is looking at doing as part of their transformation work. They need to generate two different types of care plans. There's a care plan that's the clinic's version, and there's a care plan that goes out to a patient. And the care plan that goes out to the patient also includes the patient's self-management goals. Knowing how to talk with a patient about what they really want and how that equates into behavior changes is something that is really hard to do in a 7-minute appointment. However, if you send a patient out to, say, an evidence-based program in the community where they spend 6 or 8 weeks or a year, depending on the curriculum, learning how to set small, achievable, manageable goals, that then makes for a patient that is well-educated and can really participate in not only their own self-management goal setting, but in the care plan in general. The clinic needs to have community resources available and needs to be able to make that connection. They need to show that they are making referrals and referrals that count, not just to a specialist, not just to a hospitalist, but that they are making referrals to community resources that matter. And it's all about accountability. So making specific changes, documenting it, and then showing that the work that they're doing in tandem with you all is what they need to do. And as a practice, they get points for showing this work. They also get points for handing it back so the patient leaves with a copy of what those care plans are. So being able to insert the referrals and insert the information into their EMR system makes them very happy.
We have a question.
Yeah.
Go for it.
Can you hear me, Lindsay?
I can, yes.
Okay. So if you could just back up to the slide you just left.
Sure.
Those points that you just made are now required under ACA for
Get
what
back there and I
type
will show you.
For what type of physician, too? I mean, is that everybody has to do that?
Well, if you are going for patient-centered medical home recognition,
Okay.
then you need to have these pieces in place.
Okay.
And I will also say that the Affordable Care Act recognizes the importance of community resources, referrals to community resources, and accountability of resource and referrals. But it is not spelled out yet, at least nowhere I can see, that it says exactly how that's accomplished. But the broad painting of that is that connection to community, patient-centered medical neighborhoods is where they're going. But where it's required with the care plans and the self-management goals is within the patient-centered medical home recognition.
Okay.
And are you seeing that like with a lot of primary care physician practices want to do this? And
Primary care physicians, right now, that is the primary goal.
okay.
But there's now a new specialist category for patient-centered medical homes. So while they've been primarily primary care practices, now specialists and, for example, oncologists and also pediatrics are able to apply for patient-centered medical home status as well.
If they have that status, do they get a higher reimbursement? Is that the...
Is that the carrot?
Yes.
Depends on the state. So
Okay.
there are demonstration pilots that are operating in different states so that if you are a patient-centered medical home and you've received that designation, you get a higher reimbursement rate. There are others where what happens is if you can show that you are working toward that, you will get not only a higher rate from, say, a private pay source like an insurance provider, but you will, and in fact, in many of the pilot projects, those are funded by insurance companies that are looking at this as a way to show cost savings, and then they are cost sharing with the practices that are involved. So they're looking at this as a way to lower their costs, and they're willing to pass on savings back to the clinic. There are pieces of this work, especially around care transitions, that are built into the changes that are now law with the Affordable Care Act. So you've heard about the whole readmission within 30 days, and at first it was a you've got a higher level of reimbursement, which was more the carrot, if you were within certain guidelines. Now, if you're not within those guidelines, there is a penalty, so that would be the stick part of it. So some of this is moving toward being hardwired into the Affordable Care Act and what's going to be happening with CMS and with the payers moving forward. Some of it is just within the NCQA world of patient-centered medical homes. But what is happening on the national basis, what we're hearing from organizations like the Primary Care Collaborative and from the National Council on Aging, is that these organizations, or this movement is aligning so that care plans, resources, accountability of referrals, readmission, and how you handle care coordination are all not only going to be part of what's happening for a patient-centered medical home, but what is going to be required business as usual for practices and for specialists and for hospital-based systems.
Thank you.
Any other comments or questions on that?
I don't think so.
Okay. I would be happy to send you some of the links to that information too that might kind of spell spell out a little bit of that. What I want to say just real quickly, and I know we're kind of running out of time, is what the Affordable Care Act and the NCQA says about community-based programs and what they don't say. So the National Community and Quality Assurance, when they are talking about what is needed for a self-management program, they don't specify one over the other. They also do not say it has to be something that is on the Center for Disease Control list or any other list. What they say is that if you have an evidence-based program that, or what they say is that you can have a program that is a self-management program, and as long as it's well documented, you can still get that little box checked. So if I am Dr. Bob and I create Dr. Bob's Happy Healthy Patient Program, I may be able to use that and justify it and share my curriculum and get that little box checked by the NCQA on the NCQA application. The problem is the Affordable Care Act refers to evidence-based, and Dr. Bob's Happy Healthy Program is not evidence-based. The National Institutes of Health did not pay for it. They haven't done research. It's not Stanford, et cetera, et cetera. So I may, if I am Dr. Bob, be able to check that box for NCQA, but I am putting my faith into programs that will never, ever be reimbursable, whether by a private insurance company, by Medicare, by Medicaid, and they're not seen in the same league as those that are evidence-based and either recognized by the Centers for Disease Control or organizations like the National Council on Aging. So what we say to Dr. Bob is, if you go with an evidence-based program rather than your own creation, not only do you have to bother, you don't have to bother creating it because it's there, it's evidence-based, it's recognized, but you are aligning yourself with the pilots, the reimbursement, all of the work that's being done to make these things recognized and reimbursable. So that's the sustainability piece. And I will also say that the folks that were the Dr. Bobs that wrote their own curriculum to check off the box, for the most part, are not now going for NCQA recognition, because the NCQA recognition now in the later years is much more intense around what they want, how are you using it, how are you connecting this, how is this program benefiting patients, and so that's what's coming out of the Affordable Care Act work, that's what's coming out of NCQA, that's what payers are looking for, whether they're private or public. So, but the caveat is, in the Affordable Care Act, it does not say you must use the Stanford program or you must use the CDC program. It is not that direct. But there are good cases to be made for doing it the way you want to do it. So I want to explain your homework. You thought you were just going to have to listen to me talk for an hour and a half, but you're going to have to work. So here's what we want you to do. One of the things that you have in your packet is just a little workflow sheet. Feel free to use this. Feel free, if you need prompting on how to get your brain going around this stuff, feel free. Or feel free to not use it. No one will be grading you on this. But what we want you to do is just to take a look at what we discussed today, and with the idea being that our next webinar is going to be what the practice needs, some of the more moving parts and details about making referrals, documenting referrals, feedback, et cetera, and how that plays into what you all are talking about doing with LifeSpan. But what I want you to do for the homework assignment for the next 2 weeks is to really take a look and have some conversations about where we are now and what already exists within our community, within LifeSpan, and are we already scaling up? Are we getting ready? What are we seeing? Where are the connection points? To just really do some thinking around what's possible. What's possible? What would you like to see in place? What bridges still need to be built? Knowing that part of what we're going to do over the next month or so is answer some of those bridge questions. But just where would you like to see it go? What's your vision for this work? And what is your role, both within your role with the company, but what is LifeSpan's role? What's the role of the organization in building these bridges and making these connections? So your homework is to think about it. That's tough, huh? And to make some notes. And then the next part of it is we're going to talk about an action plan. So we do this in the chronic disease program all the time. It's also in the diabetes program and a bunch of other programs. But what we want to do is have you take something that you want to think about for the next few weeks, that you want to give some time to, and come up with one thing that we're going to have you report on when you come back in a couple of weeks. So this is something that you can pursue between now and March 4th that you want to do, that's achievable by March 4th, what you're doing, where you're doing, how much you did. I'd like you to set this now and then report back on it. So the homework is to think, then to take one piece of that, come up with an action plan for one action you can take within the next 2 weeks to move forward on one of those pieces that you identified in your thinking. And what is that? Is it achievable? When, where, how much? And how sure are you can get it done? So I think we're probably going to be close to out of time, and so I'm not going to make you guys all go through and talk about this with me right now, but Joyce may make you talk about it later when we're off the phone, or somebody else may. But I just want you to know that that's what we're going to be talking about next time, is what happened within these 2 weeks, what were you thinking about, what progress did you make, and then we're also going to be talking a lot more about referrals in our next webinar. And this is how you get in touch with me. There I am. There's my email. Feel free. If there are questions, if there are answers, I will send you the links to some of the NCQA and Affordable Care Act information on how it references these. So you've got that to look at. And questions, answers?
Well, let me ask a question. Lindsay, this is Bill again. To me, this is kind of the $64,000 question, and that's how does an organization like LifeSpan, depending on the route that we take, get paid for what we're doing? And if you're going to talk about that in a future webinar, we can certainly defer that. But I mean, I guess I could see us fitting in a couple different ways. But I mean, how is there room in the reimbursement that physicians get to pay for service? Is there how do you get paid for what you do?
That's a really good question, and we are going to talk about that in the future. Okay. And I will tell you that there is no one good answer. There are a number of different moving parts in play, including healthcare, including bundled services, including Medicaid, Medicare reimbursement. I think that I mentioned to somebody yesterday that working with private insurers is a lot like dancing, because you do a step forward, a step back, a step to the side. But there are ways to cobble these things together, and in fact, we've had some luck with some of this. Some of it is just still a work in progress. And we're receiving ongoing reinforcement from the folks at, for example, CMS and their innovation grants, that they see these community-based connection programs as worthy of study because there is a way to make it work. So what that one way is, none of us have found that one magic answer, but there are a number of different ways to take a look at it, and there are a number of different ways to cobble together payment for it, depending on which direction you all want to go, whether you want to look at it as a contract service, a fee-for-service, bundled services. There are even some reimbursement pieces available. So there are many answers to that question.
Okay, great, thank you.
I wish I could tell you this is how you do it and have one. I would be very busy then, but
yeah, I mean, you wouldn't need to be running this webinar, would you?
Yeah. And so we see the light at the end of the tunnel, And we're having more and more conversations around it, but we're not quite there yet.
Yeah.
Anybody else? Got a quiet group.
Oh my goodness, yes. Well, hopefully that isn't because I put you all to sleep. So.
No.
Okay, good.
Lots to think about.
So you don't have to wait till March 4th to reach out.
We have someone asking a question.
We did end up with one question. Talk about it.
Sorry, can you hear me okay?
Just barely. Let me see if I can turn you up. Okay.
Okay, I'm just curious, are most of these models, are these based on like the 30-day readmission and reimbursement for those? Is that typically where you're focusing on at this point with this sort of program?
No, it isn't actually where we, and who is it that just asked that question?
It's Paula Jones.
Oh, hi there. So I would say that it's not based exclusively on that 30-day readmission. We are doing some work with folks that are specifically geared toward that and are working on that care transition piece and are funded to show change in that area and a reduction in reimbursement. So we have received funding in some areas here in the state to work specifically with them on where do we intersect, how can we best intersect, how can we get folks that are at risk of reimbursement comfortable in their homes and comfortable in the transition so that we can then help lower that. So our part of that readmission work is really small because what we're saying is what resources are available and when is the best time to refer people into those organizations. And so from our perspective, that is one piece of the work we're doing, the readmissions piece. What we're also seeing, though, is work possibilities within preventative care, within multiple chronic condition management, and also within the work around Medicare supplements, Medicaid. In Colorado, we have, what, 780,000 new Medicaid recipients. So we are looking at how do we help those folks who have had no access to health care and who are using ERs as their primary care physician. How do we support them in making the move toward identifying a primary care provider, a patient-centered medical home, and then making the most of community resources. So we view it from a couple of different perspectives. I would say that the readmission one, though, is a small part of what we're doing.
Okay, thank you.
Did that help?
Yes.
Okay. Anything else?
I think that really was the last one.
It was? Okay.
Yeah.
So feel free, reach out, let me know what you're working on, let me know if there's anything I can help with in terms of clarification, more information. In the meantime, we will get working on what we're going to be doing together in a couple of weeks. One of the handouts that you have is a referral process, looks like a big blue circle, and we're going to pick that apart a little bit because that correlates into not only different actions that you may want to provide either as best practices, but also some places where you can look at payment models, reimbursement models, and things as well. So we'll take a look at that next week and really kind of dive into the whole, what is a referral and how do you make it work? And thank you.
Thank you.
Thank you.
And we'll have this ready for you to post whenever you're ready.
Okay, thanks, Lindsay.
Okay, thank you all.
Bye.
Bye.
Talk to you soon.
Bye.
Bye.